Today, I'm going to tell you a story. This story is based on common scenarios found in remote Indigenous Australia today, combined with the historical facts, my own experience in remote practice, and the most recent statistics largely from the Australian Bureau of Statistics and the Australian Institute of Health and Welfare. In this story, Stella and Rob live in Nabvana. I will paint the human face onto the remote health landscape and apply this information using the social determinants of health and a social justice perspective. This remote health story describes a week in the life of an Indigenous family who live in one of the 1,216 discrete remote Indigenous Australian communities. The characters and the community are fictitious. The story is based on a primary healthcare approach to health, which emphasises equity, equality, affordability, appropriateness, accessibility, and social and economic justice. The story I'm about to tell you is about difference. It's about difference in culture, difference in geographical location, and when we put those two things together, we get a great difference in health outcomes. I call this the triple whammy. So sit back and listen to the story and let the stats wash over you. Nabvana is a small community in the tropical coastal country of Northern Australia with a population of about 1,200 people. 95% are Indigenous and come from 5 different clan groups who were historically grouped together under the Act. The remaining 5% are non-Indigenous and they provide some of the educational, health and other services to the town. Nabvana looks picturesque on the ocean with lots of palm trees blowing in the breeze. The community has about 150 houses and 30 other dwellings. Here are some facts about housing in remote communities. There is also a local council building, a community store that sells food and a few kids' clothes, and a takeaway shop, a flash new hospital building surrounded by a big fence, and a police station. Opposite is a school that takes students up to Year 10, a big football field, a post office that also provides banking services Monday to Friday, and there's a wharf for fishing. Electricity and water are available in most of the houses, but they are constantly unreliable. Here are some facts. There is an airstrip which was sealed in 2010 and will have lights for nighttime medical evacuations very soon. There is a big building near the airport for the new electricity supply, though it keeps breaking down. Most of the people haven't changed over and still rely on the community generator or their own generators for electricity, and there are constant sewage leaks and overflows and poor maintenance. Here are some facts about maintenance in remote Indigenous communities today. There's no particular industry in Nabvana, though there is good fishing and a small and growing crafts centre. 2 artists from the community have made it big in the city and they act as mentors for some of the gifted young people. There is a mine about 150 kilometres away, though it has not employed many local people for the past 20 years. Here are some facts about unemployment in remote Indigenous communities. Apart from those who are employed and provide services in the community, most people are unemployed and they work for the Remote Jobs and Communities program, which is a bit like a work for the dole program, or they're on a pension. On the RJCP program, people do a variety of work such as community development work and council work 2 or 3 days a week. The shop tries hard and flies in fresh fruit and vegetables every Thursday. Here are some facts about food supply in remote communities. Usually by Monday, there are only a few ripe bananas left, along with tinned and frozen food. The diabetes workers from the health centre have been working with the shop manager to improve its food selection. But the price of food continues to be exorbitant. On pay week, about half of the men and a third of the women have a drink at the local club, which is open for 2 hours, 5 days a week. The grog is twice the price that it is in Fairville, the closest regional town. Some men drink too much, and many become violent. So there is a safe house for women to go to when their husbands have been drinking too much. It's run by a small group of older, respected women known as the Night Patrol. At number 12 3rd Street, on the outskirts of Nabvana, live a couple called Stella and Rob. They have 2 children, George, who's 4, and Henrietta, who's 7. Stella is 35 weeks pregnant with their 3rd child, whom she secretly hopes will be a lovely little girl just like Henrietta. Also living with them is Stella's mother Doris and her brother Julian, who's 18 years old but always in trouble. Stella's dad died last year from a heart attack. He was only 52 years old. Here are some facts about life expectancy in Indigenous Australia. Rob's family all live in Nabvana too, and sometimes his relatives and their kids come over and stay, but not so often since Doris has been living there. You see, Stella fell in love with Rob, but he was from a different clan group, and at times there's been a lot of fighting between the families. They think that Stella should have married a man her parents chose for her to marry, an older man from her own clan group. It caused a lot of trouble at the time. Stella works part-time at the local school as a teacher's aide, and she loves her job. She went up to year 10 at school and always wanted to be a teacher. Here are some facts about access to education in remote Australia. Stella enrolled in the Remote Area Teacher Education Program to attain a teaching qualification, but a lot of it was done over the internet, which was very slow and unreliable in remote communities. It was just too hard with the kids to look after as well. Stella would love Henrietta to be a qualified teacher one day and come back and work in Nabvana, but that would mean she would have to leave her family and the community and do grade 11 and 12 and then go to university for an additional 3 years. Plus she's heard it's really expensive, and on her salary it probably won't happen. So what do remote Indigenous people earn? Here are some facts from 2011. Rob works for the RJCP program 3 days a week. This week he's working with the Community Council, painting the new lift that they've installed on the wharf. Stella is becoming anxious because next week she has to go into town and wait for her baby to be born. All pregnant women in remote communities have to go into town at 36 weeks and wait in a hostel until they go into labour. But today Stella's had a few pains and fears it will be like last time when she had George and that the baby will come early. Maybe that will be good, she thinks, as she's been nervous about having to stay in hospital with all those other people for such a long time. She also worries about who will look after the kids. Her mum Doris is too sick and cranky to look after them properly. She's a diabetic with kidney problems, which are very common in remote Indigenous populations. She's also come into Fairville for a few days herself during that time for an appointment with the renal specialist. The specialist thinks Doris will probably have to start on dialysis soon, like several of her relatives from Nabvana South, where they have their own dialysis unit. Also, without Stella's income, it will be difficult to cope financially. However, she doesn't want to go in yet, not before Rob's auntie's funeral on Friday. Stella sees the visiting aeromedical doctor on Thursday afternoon. The doctor tells Stella that she needs to come back with her on the plane that night, as she may be in very early labour, and it will be safer to transport her then. Stella goes home to get her things and say goodbye to her family, who come to wave her off. Henrietta cries. She will miss her mother, but George is fascinated by the aeroplane and he wants to go too. Stella delivers a baby boy, Arnold Francis Luke, at 2 a.m. on Friday. He's a lovely little boy who's about 4 weeks early and weighs 1,650 grams. Stella thinks he looks just like George when he was born. He has a bit of trouble breathing, so they take him down to the neonatal nursery where they put tubes all over his body. And Stella's very worried about him. When they move her down to the ward, she goes onto the veranda to have a smoke and bumps into one of Rob's relatives, who's a patient in one of the other wards. It's really nice to see a familiar face, she thinks. Stella tries to ring Rob and tell him about the baby. She has to ring Marcy at the community council office and leave a message for Rob, as they don't have the phone on at home. She knows the whole community will know by the end of the day, now that Marcy knows. Marcy tells Stella that her brother Julian has been arrested again, this time for taking the police paddy wagon for a drive when he was stoned. He'll probably have to go to the big house this time, she thinks. The next 10 days are touch and go for Arnold. He's more premature than anticipated, and he's having some breathing problems. Because of this, he's having trouble breastfeeding and is fed via a nasogastric tube. As Stella is just a bit anemic and the doctor says she can go home and come in and feed Arnold. Doctors never understand it's not quite that easy if you don't come from Fairville, she thinks as she averts her eyes. During the next 28 days, the neonatal period, Arnold is twice as likely to die than other Australian babies. If he was born in Western Australia or the Northern Territory, the likelihood of his dying increases by 2 to 4 times respectively. By the time he reaches his first birthday, he will be 4 times more likely to have contracted meningococcal disease and 3 times as likely to be hospitalised for pneumonia. If he was born in Western Australia, he would be 14 times more likely, or in Central Australia, he will have contributed to the highest incidence in the world. Arnold will be 3 times more likely to be hospitalised for infectious and parasitic diseases compared to non-Indigenous infants. Between his 1st and 5th birthdays, Arnold will be 5 times more likely to contract hepatitis A, twice as likely to be admitted to hospital for asthma, and 12 times as likely to contract rheumatic heart disease if he lives in the Northern Territory, which is one of the highest incidences in the world. He will have a 90% chance of contracting otitis media and be 4 times more likely to have developed a hearing loss by the time he starts school. Between his 5th and 14th birthday, Arnold will be growing more slowly and be shorter than his cousin who lives in the city. And he will be 43 times more likely to be hospitalised for malnutrition. He's 20 times more likely to suffer from scabies that will become infected and lead to glomerulonephritis. He will have a much greater likelihood of suffering learning difficulties at school due to his hearing problem and have a 35% chance of reaching the National Year 7 reading benchmark. He will probably not complete secondary school. He will be twice as likely to die before the age of 14 than other Australian males. Between receiving his new football for his 14th birthday and adulthood, Arnold will be twice as likely to be a smoker, 45 times more likely to have been involved in family violence, 5 times more likely to be admitted to hospital due to assault, and 13 times more likely to be jailed, and 7 times more likely to commit suicide, probably by hanging, than other Australian males. Should he survive, by the time Arnold marries his true love Cynthia at 25 years and they settle into Nabvana and have their 4 children, there is a 90% chance that he will mostly work for the RJCP program. Throughout his adult life, Arnold will be 3 times more likely to suffer from type 2 diabetes and be hospitalised 3 times more often for this disease than other Australians. Arnold will be 8 times more likely to die from kidney failure. If he lives in the Northern Territory, he will die at about 52 years, and if he lives in remote South Australia, he will die at about 48 years. During Arnold's lifetime, he's likely to have attended more than 100 funerals. He will have earned 65% less than the average Australian and have paid twice the price for his food and goods during that time. Despite the fact that Arnold has lived with 3 to 4 times the amount of health disadvantage as other Australians, he has had far less access to healthcare professionals during his life, and the amount spent on his healthcare is similar to that for other Australians in low-income groups. Like his parents before him, Arnold is less likely to ever get to play on the level playing field unless something is done to break the cycle of poverty and disadvantage, the poverty trap, that he was born into. This fictional story is what Arnold and others like him born this year have to look forward to in life. These discrete remote Indigenous communities, which exist in most states, are a direct result of restrictive and paternalistic government policies that place different clan groups of Indigenous Australians together. There is no consideration that over 500 groups were different, with different laws and different cultural practices that excluded them from intermarrying and living harmoniously together. The policies of the day saw that everyone should be the same. There was no place for difference. Yet it was on the basis of difference, cultural difference, that they moved these clan groups together in the first place. I believe that every Australian has a fundamental human right, their right to health, housing and education, which are as important as political and civil rights. I invite you today to think about the lives of the people you will be working with in the future and the possible impact you might be having on them. I invite you to not only look at them as the broken leg, the diabetic, the renal patient, but as people who in their daily lives are affected by the basic things that we take for granted: electricity supply, clean water, healthy food, control over our lives, and that thing called choice, and what that means for them in their lives. These things, the social determinants of health, are those things that determine whether we're going to be healthy or not, and they can account for 90% of our health. The remaining 10% of our health is determined by those things that we as health professionals can provide, such as strapping an ankle, prescribing medication, providing counselling and hospital services. Therefore, we know that more doctors and nurses and hospitals don't make better health. They only provide health services and infrastructure, which contribute only 10% towards our health. So let me summarise using the evidence about what we know about health and the social determinants, using what I call the cycle of poverty. Research tells us that to be poor means to be unhealthy. Poverty is linked with all aspects of people's lives. It's linked with our ability to access good education, which affects our ability to find a good job, which affects the type of housing we can live in, and the food we can put on the table for our children. Being unemployed doesn't make us feel good about ourselves. It does not allow us to have real control over our lives. This, therefore, often makes us depressed, whereby we drink more grog to make us feel momentarily happy. We get more stressed, we smoke more, and we worry about how we're going to feed our kids that night and pay the mortgage. And this, in turn, affects our family relationships, our social support systems, and restricts what we can do socially. This whole process of being unemployed becomes a vicious cycle that places us in a certain social class, the unemployed, and can turn into what we call the cycle of poverty, which can be passed down from generation to generation because we know nothing different. Therefore, what this basically means for our health is that if you're rich, you can live longer and be healthier than if you're poor. Now, let me add two more contributing factors. The first is our culture, and the second is our geographical location. These are the two things that differentiate Indigenous and rural Australians from the rest of Australian society and form what might be seen as the double whammy when we put it together. Research tells us that to live in rural remote Australia means that we will probably be poorer and certainly less healthy, and that this gets worse with remoteness. I would like to make the point here that this is not consistent with Indigenous groups in other First World countries, such as the Māori in New Zealand and the First Nation people of Canada. Australia continues to have infant mortality rates that are almost double the Canadian First Nation people and 1.4 times the New Zealand Māori, which of course worsens with remoteness. This story about Rob and Stella's family provides an overview of the life and the future of an Indigenous family living in a very remote Indigenous community today. It raises issues that are directly related to poverty and draws out what might be needed to break the poverty cycle. It draws out those issues that impact on our health, the social determinants of health, such as our health status at birth, our access to education, housing, food, whether we have clean water supply, sewerage, and whether we have a job, because with a job comes an income, which gives us choice and control over our lives. It emphasises the direct relationship between the rich and the poor, and if you're rich, you're going to live longer and be healthier than if you're poor. So as health professionals, we have a responsibility to work together with Indigenous Australians to improve this situation, to ensure every step we take is culturally safe and enables remote Indigenous Australians to get to play on the level playing field.